Hi, everyone. Good afternoon. Nothing like a little bit of reggaeton post-lunch to, get us grounded, get us ready for an awesome session. I'm very excited about this session. The reality of harm reduction is that we serve the people who access our services, but drug use doesn't exist in a vacuum. People show up with different identities and different intersecting identities. We also need to be responsive to the different types of drugs people are seeing and the emerging drug trends. Full spectrum harm reduction is tailoring our programs and services to the most marginalized because we know that when we do that, everyone can benefit. It is supporting and resourcing people who are tailoring and advancing services within their own communities through their community lens. These programs that you will hear from today are doing just that. But before I turn it over to them, I'm pleased to introduce myself. Soy Justice Rivera. I use ella, ella, she, they pronouns. I am a queer pleasure activist, harm reductionist, mixed Boricua, Taino, Jewish, and I am also a sex worker and a drug user. I am a partner with Reframe Health and Justice Consulting, and how we practice full spectrum harm reduction is through capacity building assistance, technical assistance, policy advocacy, and organizational change work that really centers sex worker-centered harm reduction and healing-centered harm reduction. I am going to focus on talking about sex worker-centered harm reduction today because during the next session, we have a workshop on healing-centered harm reduction, which we use as a framework for creating healthier organizations and healthier movements, and I hope to see some of you there. So what our work in sex worker-centered harm reduction looks like is working with overdose prevention programs, SSPs, GLBTQ liberation programs, and anti-violence programs to create comprehensive services for people in the sex trade and for you all, people in the sex trade who use drugs. We come from a US and Puerto Rican context, and there is a federal law called the Anti-Prostitution Pledge that actually has been found unconstitutional, but continues to be used today because new guidance has not been written on it. And what that means is that no federal funding can go to support sex worker-centered harm reduction. So sex worker-centered harm reduction has to happen through HIV prevention and care streams, through LGBTQ care streams, and through anti-violence. So I'd like to read to you some of our core competencies of sex worker-centered harm reduction. The first is recognize that everyone has a unique constellation of experiences. The second is allow everyone to determine their own goals about participating in the sex trades and use the trans-theoretical model to approach change. The third, understand the role of criminalization and policing on the experience of trading sex and how that may impact the experience in service provision. The fourth, address anti-sex trade stigma within your organization and interactions. And the fifth is to develop agency-wide policies and practices which lower the barriers to engagement and share them with partners. We believe that for a SSP and overdose prevention program to comprehensively serve sex workers, that violence prevention and response needs to be just as much of a priority as overdose prevention and response. And so if you're interested in hearing more about that, I am part of a group of BIPOC and mixed race folks who created an anthology called Body Autonomy, Decolonizing Sex Work and Drug Use. There is a lot about sex worker-centered harm reduction, stimulant harm reduction, and also what the continuum between harm reduction and healing justice looks like in this book. We have two of the articles available in Español. Uno es Panorama de la Reducción de Daños en la Industria del Sexo, y el segundo es Goce Transnegra, una carta de amor a Ampola. And that's actually one of my favorite. It's by Presto Cresto, and it's his story of moving from gender dysphoria to gender euphoria using opiates. If you would like to purchase these, all the donations for the Spanish articles go to Coaquia, which is the only peer-led harm reduction program in Puerto Rico. And then all of the proceeds from the books go back to the BIPOC Collective. And Gabby over here will be selling these after the session. So they gave me the mic, so thank you for my shameless plug. I also wanted to talk a little bit about where it is that I'm based, my motherland, Puerto Rico. Puerto Rico is a place that it has many beautiful oceans and mountains, caves, and bioluminescent bays, but the land has been exploited for over 300 years. Currently, we are a failed colonial project of the United States of America. What that looks like is that we are half citizens and that there are tax cuts for wealthy Americans to come to our land and not have to pay taxes. And that has created a huge wealth disparity where the rich can come and get richer, but poor, mostly Puerto Ricans and Afro-Caribbean people, only struggle. And that's created a situation where we see a lot of people doing sex work to survive and hopefully even thrive, and also a lot of drug use without a lot of ability to do services. And so mutual aid is the name of the game, and collaboration is the name of the game, and we have amazing harm reduction programs, Boricua harm reduction programs, who are with us here today. I'm on the board of Guaquia, as I said, the only peer-led harm reduction program in Puerto Rico. And I'd like to invite one of my fellow board members up here to talk about the program. So Angel, would you like to join me?
Gracias, Justice. Muy buenas tardes. Mi nombre es Ángel Casillas Carmona. I'm going to speak in English so the benefits of everybody. If somebody doesn't understand something, I can repeat it in Spanish. As I mentioned, my name is Ángel Casillas Carmona. I am the administrative coordinator for Guaquia. Guaquia is a peer-led, peer-created, and we were created in 2019 by drug users to serve drug users. And we serve the San Juan area in Puerto Rico, which is the capital of San Juan. Today, I am joined by our founder and director, Gerardo Jones Medina, who is over there. Gerardo is the brave soul that goes out to the streets 2 times per week to serve our communities. We do savings exchange programs. We also provide safe smoking supplies for our people. We also provide education, not only on harm reduction, but also on the war on drugs and how it affects our people, and more importantly, about human rights. We began our journey and our dream in 2019 via a donation from Intercambios Puerto Rico. I would also like to acknowledge some of our allies that are here today in the room. Justice, who is part of our board, Gabriela, our people from Oasis de Esperanza, Urbavie, who are colleagues from us in Puerto Rico, and we do the good work of providing services to our communities. In 2021, we began receiving grants, and we've been steadily receiving grants for the past 3 years, which has helped us to continue to do our work in Puerto Rico. I have some pointers. Gerardo wanted me to speak, but he wanted me to say some particular things, so let me double check here. Weekly, we serve between 100 to 120 participants. We not only serve individuals who use drugs, we also serve the community in general. We provide materials for sex workers. We also work not only with men and women, we also serve the trans community in San Juan. And some of our biggest achievement is that since our beginning, we have gathered 45%. We not only provide syringes, but we also take back from the community because that is part of the policy that we want to provide. And as of now, we have a 60% in terms of the captation that we have from the syringes. So we provide syringes and we get 60% of those that we give back. And the work that we do is so important because there's little to none services for people who use drugs in Puerto Rico. There's a lot of stigma, and the drug on wars affects our population indiscriminately. And as Gerardo mentions constantly, the war on drugs is a war on people. And Guaquia means in the Taino language, ours. And that's what we try to convey to our community, that this space is for them, and we do it for them. Thank you for having this space. Thank you, Justice.
All right. Thank you all very much. Our first presenter. I found it. Okay. Our first presenter, I'm really sad, could not join us here today. We did a prep session with her. Her program sounds absolutely amazing, but she had some visa issues. And so she was able to join us virtually, and so I'd like to introduce her before we play her slides. So Poonam woman is going to be presenting on enforcement of harm reduction, prevention, healthcare, and treatment services for women who use drugs in Nepal. Poonam works with Recovering Nepal, a network led by people who use drugs and people in recovery, and her focus is on advancing gender-sensitive harm reduction services for women who use drugs in Nepal. She is especially passionate about the intersection of public health, human rights, and social justice for marginalized women. Daniel, vaya por favor.
Hello everyone, it's me Poonam from Nepal. I hope you all are having a great time in Bogotá. I was truly looking forward to being there and attend the conference in person, but due to some reason I was unable to attend the conference. However, I'm very much excited for this opportunity to connect with you all virtually and share my abstract. So I'm very excited to dive into today's discussion. So talking about my abstract title, it is Enforcement of Harm Reduction, Prevention, Healthcare and Treatment Service for Women Who Use Drug in Nepal. So I work as a program officer here in Nepal, and my organization name is Recovering Nepal, which is the National Federation for People Who Use Drug. So I have presented my overall abstract within this poster. You can go through it. I have also inserted some of the pictures related with my abstract that our implementing partners conducted. So you can go through it. So talking about the partnership and collaborative approach of WIP healthcare program in Nepal, the commodities, supplies, and monitoring and evaluation part is done by the government of Nepal. MOSP, which is the Ministry of Health and Population Supplies, Kyrgyzstan, whereas NCASC, which is the National Center for AIDS and STDs Control, supplies clean needles, as well as they supply HIV and HCV testing kit to our service recipient. Whereas SWC is Social Welfare Council, who do the monitoring and evaluation part within our implementing partner. So our grant supporting agency is Wave Healthcare, which is the pharmaceutical company based in UK. Recovering Nepal manage the program activities, whereas our 4 district implementing partners are Ekta Nepal from Chitwan, Asa Foundation from Ripponde, Sian Drop-in Center from Makwanpur, as well as the Damayanti Foundation Nepal from Bankhe. So talking about the background, as we know that in the context of Nepal, it is purely male-dominated society where there is a limited harm reduction services for women who use drug. So our project mainly focuses on 4 districts of Nepal, that is Chitwan, Makwanpur, Rupandai, and Bankhe. The main target population is women who use drug in Nepal. So I have also illustrated our district partners within the map of Nepal. You can see over there. So we set the target in regards with the SDG 95, 95, 95. So the total reached of the service recipient till August 2024 is 850. So the national size estimation is done by the government of Nepal. So we set the target related with 95, 95, 95, and we reached 850 till August 2024. So I have also wrote the source where the estimation has took. You can go through that source too. So the project design and the key services that our implementing partners are doing, I will be discuss this over here. So at first, there is a needle serious accidents program for women who use drugs throughout outreach services. We also do HIV and hepatitis C testing. We do provide education on sexual and reproductive health. We also provide HIV/AIDS awareness program, whereas we do have conducted community-based harm reduction initiative. We provide referral services, drug treatment support, emergency fund in case there is emergency such as abscess management case, overdose case. If there is some legal issues, we use that emergency fund. And we do have primary checkup once a month. We have a doctor in our drop-in center. They visit us once a month and check our service recipient health. So we conducted a secondary service within 815 women who use drug across 4 districts of Nepal. So 90% of the recipient survey supported current harm reduction services, whereas 10% requested additional gender sensitive services such as legal support. They want child custody help. They also want nutrition support, citizen support. So this is our key finding. Talking about more, 25% of our service recipient faces police harassment, whereas 25% suffer from stigma and discrimination in healthcare setting, whereas 35% demanded women-friendly as well as free rehabilitation center and services for them. So here are some of the recommendations that we find out throughout our survey. So at first, strengthening the behavior change communication because it helps in promoting safer injecting, reduce stigma and discrimination within our community. Also, another one is enhancing the IC material on HIV related IC, which will help to increase awareness and understanding HIV prevention, testing, treatment within our key female vulnerable population. Whereas we also find out that there is a need of expansion of harm reduction services globally, as VIP Healthcare only look after for district of Nepal, but there is a need of extra harm reduction services geographically. And after this recommendation come, we have successfully organized BCC session, as well as we have made IC material which is related with HIV from harm reduction momentum grant by VIP Healthcare project, which is implemented from August 2024 to July 2027 within our implementing partners. So this is our key achievement for now. Although we are in process of expanding harm reduction services globally too. So this is my overall abstract that I have presented over here. So thank you for your patience and thank you for having me over here. So if you have any queries or questions regarding my abstract, please feel free to email in the given email address, or you can contact me if possible. But I think the best way is to contact me by email. So I have mentioned my email over there. So thank you very much for everything. I want to especially thank the Harm Reduction International team for giving me this opportunity. Okay, thank you. Namaste.
This is being live streamed, so Poonam, I'm hoping can feel our love from this room. That was an amazing presentation. And I'm excited for what's next. I have had the pleasure of getting to know Gayane a little bit over the last couple weeks as we've been preparing for this workshop. And she's doing really interesting work. So her presentation, Gayane Arustamyan, is presenting on high stakes confronting the NPS epidemic in Kyrgyzstan and its public health fallout. Gaia, as she is nicknamed, is an independent consultant with more than 13 years of experience working in global health, human rights, and harm reduction programming. Gaia particularly focuses on the Eastern Europe and Central Asia regions, where she worked exclusively with partners from Ukraine, Georgia, and Kyrgyzstan in particular. Gaia is joined today by her colleagues from Kyrgyzstan, the PWUD-led network, Attica, who will also be happy to answer any questions you may have.
Good afternoon, everyone. I think the slides are for the next speaker.
Los otros slides, por favor. El otro. We kind of screwed up, although we last minute changed some things, so it's not Daniel's fault.
Gracias. Buenos días. Hi, everyone. So my name is Gaia, and I'm really glad that you all came here today in the afternoon. So today we'll be taking a closer look at the growing issue with new psychoactive substances in Kyrgyzstan, a country that some of you may have never heard of, or maybe it's really challenging to pronounce, Kyrgyzstan. So I know it's a challenging word to say, but so together we'll explore what NPS is, a look at the global and regional context, the situation in Kyrgyzstan, current challenges, the community-led research on NPS that was conducted by Attica and my colleagues here who are together with me, and also a few other representatives from Eastern Europe and Central Asia, particularly from Ukraine. Slava Ukraini! Thank you. And by the end of the presentation, we'll discuss the strategies for confronting the epidemic. But before I dive into what NPS is, and particularly what NPS in Kyrgyzstan is, I would like to actually talk a little bit about the country that probably, as you already, I told you, probably haven't heard of. I had a privilege to go there once in my life. I hope there will be many more times to do that. But Kyrgyzstan, as you can see on that little photo on the right side, is nested in the heart of Central Asia, and it's known for absolutely breathtaking mountains that take up over 90% of the country. And there's also the Asian Silk Road that also crosses through that beautiful country. Its people are proud of their nomadic culture, celebrating traditions like horseback games and yurt building, and one of the longest poems in the world. There are more than 80 ethnic groups, including Kyrgyz, Uzbek, Russian, and Uyghur, and it's truly a multicultural society. An interesting fun fact is there is a lake, as you can see on the little photo below, Issyk-Kul Lake. It's truly a magical place. It's one of the largest alpine lakes in the world, and it never freezes. So whatever the harshest winters are in Kyrgyzstan, it never freezes. And it's truly a symbol of endurance and mystery of Kyrgyz culture and Kyrgyz society. So while Kyrgyzstan rich traditions and strong community values are a source of national pride, it still grapples with a lot of challenges, and particularly with challenges related to new psychoactive substances. And it's no surprise that the NPS has been on the global health agenda for quite some time, almost more than 2 decades, particularly in Eastern Europe and Central Asia. And it has become a global phenomenon with 147 countries reporting on one or more NPS to UNODC early warning advisory. You can see on that slide on the right side that indeed it impacts very significantly Eastern Europe and Central Asia region, but also Northern America and quite a significant part of Western European countries. So why Kyrgyzstan has become vulnerable to this epidemic? Because of this geographical location. Countries like Kazakhstan, Kyrgyzstan, Tajikistan, and Turkmenistan and Uzbekistan are particularly vulnerable to NPS because of their location, because of the location of the trafficking routes and standing between the major drug-producing regions like Afghanistan and also large consumer markets like Russia and European region. The market is highly dynamic and resilient, characterized by high turnover of potent, cheap, and available substances. So what are the current challenges that we see manifested in Kyrgyzstan related to NPS? First of all, it's absolutely inadequate legal framework. There are huge legislative gaps that delay regulation and enforcement efforts, and existing drug laws may not keep pace with the rapid emergence of new substances. There are also massive difficulties to detect NPS in toxicology tests and limited laboratory capacity for specialized testing. Lack of public education and awareness. Basically, general population and particularly young people and adolescents are not aware of the risks associated with NPS use. There is insufficient preventive education targeting youth and vulnerable populations. The healthcare facilities are insufficiently adapted to address this situation, and healthcare providers often lack specific training to identify, treat, and manage NPS-related cases. And there is, of course, social stigma and lack of support services and gender-related barriers that are particularly pronounced among women who use drugs in Kyrgyzstan that has been increasingly prevalent among this population. When it comes to public health fallout, all these challenges, they bring this situation to an increase in rise in overdoses and emergency room admissions. So the unpredictable potency and composition of NPS have led to a sharp increase in overdoses and emergency medical cases, overwhelming the emergency rooms. There are, of course, mental health implications related to depression and suicide that is strongly linked, and all of this having a huge strain on healthcare systems. And this is all compounded by a lack of treatment options or services tailored for NPS users. So what is the actual situation with NPS in Kyrgyzstan? As of January 1st, 2024, there were 12,568 registered HIV cases in Kyrgyzstan. People who use drugs make up to more than half of these cases, with HIV prevalence over 16%, and that is 70 times higher than in the general population. There's an estimated number of more than 17,000 people who inject drugs in the country. But however, this number does not include NPS users. And that is the main reason and the main objective for doing this community-led research that we have conducted together with Attica. And this highlights the need to do it and to continue doing to understand the evolving patterns of substance use. So what is the research that has been conducted by Attica in 2024? In collaboration with Input, we conducted a study using a mixed method approach. So surveys were administered to 100 NPS users and 30 healthcare workers across 3 regions of Kyrgyzstan: Bishkek, Oshin, Chuy. The study assessed the adaptability of current HIV prevention and treatment services, identified challenges and proposed solutions. The main objective of this study is to inform the biggest donor in Kyrgyzstan, Global Fund, to ensure that the programs for people who use drugs are adapted to the current challenges, which is not the case right now. Unfortunately, the current program is not adapted to the NPS situation, and this has to be taken into account now that there is a discussion ongoing about the next grant cycle 8. So, moving on to the key outcomes of the research, there has been quite a few. So, first of all, the team has done quite substantial legal analysis. There were more than 190 legal cases, criminal cases reviewed, and 70 selected for the analysis, showing a significant presence of synthetic drugs. Methadone and alpha-PDP, known as bath salts, particularly in Eastern European region, together make up almost 46% of the synthetic drugs market. Other prevalent drugs are MDMA and spice, followed by heroin, cocaine, and smaller shares of LSD and mushrooms. Here I need to make a clarification on heroin. The drug has completely disappeared from the country, and it only appeared for only a very brief period of time between spring and fall 2024, which was also included in the research timeline. So that's why we see that there is 12%. However, this is not the case now. There's no heroin in the country, which is also explaining why there is such a high increase in NPS consumption, because there's basically no drug that has been historically preferable by the drug user community. When it comes to legal and criminal data analysis, I realized that there was a slide that was not updated, but in any case, there was also, of course, an expansion of online drug markets, and 39 active internet drug shops were identified in Bishkek, with nearly half specializing in synthetic drugs. We could also see throughout this analysis that the intensity of consumption increases very much in the nighttime, so it's up to 30% over general timeline. All of this highlights the fact that this situation necessitates continuation of community-led research and harm reduction services due to stigma and close nature of this online community. It's essential to continue this research, to fund it, to reach hidden populations, to understand new trends, and design effective user-centered harm reduction services. I would like just to give a little brief about what is the model on NPS that was developed by Attica. So it's a 3-day modular training that was developed with the support of EPIC project. It's a global health initiative that is funded, well, was funded, unfortunately, through FHI 360 and USAID, with a focus on understanding NPS, its health impacts, overdose prevention, gender-specific needs, online and offline counseling strategies, and legal and ethical issues. It emphasizes empowering peer navigators in using gender-responsive methods to better serve people who use NPS, especially women who use drugs, who are facing compounded risks. And participants of this training are trained in motivational interviewing, harm reduction strategies, communication skills, mapping services, etc. And the emphasis in both on online outreach and field-based work. So to summarize this presentation, of course, as I've mentioned several times, there is an absolute need to continue supporting the community. We need to monitor and analyze the trends that are happening in the country with the current situation, because it's unfortunately, even with the current funding that is in the country, as I said, it's not adapted to the evolving drug scene, and this needs to be taken into account. So first of all, on the policy level, it's important to take into account that the legal framework will also need to be updated, and there is also an obvious issue with banning emerging substances, and also it's important to involve UN agency, in particular UNODC, and collaborate with neighboring countries like Kazakhstan, Uzbekistan, to share intelligence and best practices. When it comes to public health approach, it's important to introduce and provide services like drug checking, safe consumption advice, naloxone distribution for overdose reversal, and low threshold care. Educational campaigns, particularly targeting young population and youth outreach, are critically important right now. The healthcare system and the public health fallout that I mentioned previously, it's also important to ensure that the medical professionals are trained and they understand that the situation is radically different than compared to 5 or 10 years ago. So the curriculum for emergency doctors needs to be updated. The nurses and frontline workers need to recognize and manage NPS intoxications or withdrawals. And last but not least, technology and policing. So it's important that while we're working on community-led research, we also take into account the situation with a predominantly online drug market, and that needs to be also taken into account, that we need to follow and understand what is happening with the darknet market, with the Telegram channels, and what's happening out there. And I think this is it. So I found that in Kyrgyz language, Chong Rahmat is thank you. Happy to answer any of your questions. Thanks.
Amazing. Thank you so much, Gaia. One of the things that I really appreciated when I was invited to chair this panel was that full spectrum harm reduction, a lot of what I thought that was about was gender inclusive services and culturally inclusive services, but really like the lens that Gaia got to bring to this, that it also means that we have to be responsive to emerging drug trends, right? It's not just about the people, it's about the drugs too. And so thank you so much for presenting all of that. And one of the things when Gaia and I talked to is that she would really like to know what other countries have been doing to respond to emerging drug trends, what the successes and challenges have been. So maybe when we move over to Q&A, we can hear from some of the audience about that. So next, I'm really excited to introduce Mathieu. Mathieu Morin Robertson, did I say it right? Okay, cool. Is going to be presenting on Indigenous navigation, a harm reduction approach adapted by and for Indigenous peoples experiencing urban homelessness in Montreal, and he's joined by a colleague.
Koi casino, Mathieu Teshin Cashin, Nepekogami Nwats, Finish Compton. Hi everyone, my name is Mathieu Robertson. I'm a Pekwagami Nwats. I mean like a Innu from a little reservation called Mathieu. I would say up north Quebec, but not that north, like medium north. I'm really happy to be here. I'm not so comfortable to do speeches. I feel more comfortable in a shady alley doing stuff. I'm more a field person than a speaking person. But I'm also feel really grateful because since I'm here, I feel super emotive to listen at everybody that speak here. For me, as a young Indigenous person that come from a little community, from an Indigenous woman that was proud, strong and resilient, that raised us with everything she got. It's a real, I'm really surprised to end up here right now to speak with people. So I'm really grateful to be here. I'm a bit stressed about talking here because I'm not really, as I said, used to do like big presentation. And I'm gonna speak in English. Yo podría hacer en castellano, pero I don't like to speak so much colonial language, so I'm gonna just choose this one, but I speak French usually, so I might sound weird a little bit at some point, but anyways. So yeah, I'm gonna let my coworker present herself. Yeah, I'm pretty happy with her.
Merci, Mathieu. I'm Stéphanie Marsan. I'm a family physician and medical director of the Addiction Medicine Service at the Centre Hospitalier de l'Université de Montréal, which is a bit of a mouthful, so we like to call it the CHUM. And it's an honor to be presenting with you today.
So yeah, I used to work for 2.5 years as a coordinator and a navigator on a Doctor of the World, an Indigenous navigator. And I'm really proud to be talking about that today because I'm gonna tell you right away, I never studied in like navigation. It's kind of a new thing that we developed like by trying stuff. So I'm pretty happy to present that to you today. Doctor of the World is a big organization. It's an international health organization with 17 delegations working in over 70 countries. I read it. Our goal is to promote a universal access to health care and support excluded and marginalized individuals and communities in their claiming for the right to health. And in fact, I work with a really, really awesome team of super radical people that work a lot to go reach the people that nobody want to reach usually. So in our work in Canada, because we have international work, but I work in the national division. And in Canada, we have a clinic for immigrants with precarious status with a community outreach program that's led by peers that had like difficult process of status in Canada, and they are able to reach people that nobody can reach, so they are super awesome. We also have a mobile clinic that I was more involved, that go in the street of Montreal and work with homeless person and give health services to a lot of big population all around Montreal. We have a peer-led harm reduction program that we work, and that is coordinated by our peer also, that do awesome stuff and teach me so much thing about like peers and approach and harm reduction approach. We have a mental health program that we had, I don't remember how many psychologists, but more than 5 or 6 that work with community worker in Montreal to help them to do their work, and also with people that live in street and are homeless to have like access to free and like a long-term support by psychologists. And we have the Indigenous healthcare program that was part, is led by everybody is Indigenous in the program, and we had like a team of 5 Indigenous navigators and a clinic that's led by a nurse that is Anishinaabe, and she's a practitioner nurse that works in a center in Montreal, the Friendship Center, that's a center for Indigenous homeless person. The button. I feel pretty boring in English usually. I do more joke. I'm gonna try to do more joke later.
And so the CHUM is a tertiary care hospital in downtown Montreal. It has a super regional mandate, so even though it's in Montreal, it really covers the entire province of Quebec. And it has an addiction medicine service that provides, that includes an outpatient clinic, which provides withdrawal management, opioid agonist treatment, STBBI screening and treatment. We have an inpatient detox for people who are at risk of withdrawal complications. And we also have a consultation liaison service for the hospital so that people who are hospitalized on other units throughout the hospital have advocates who are making sure that their needs are being met. We use a harm reduction approach so that if people do not want to be to stop using while they're in the hospital, we make sure that they are able to continue to use their substances in a positive way. We have, being a hospital, we have always worked in our own little silo. And through the years, we realized that that wasn't the way to go about doing things to really facilitate access to care. And so we started partnering with community organizations, with Indigenous communities, to really try to get and provide that access to harm reduction and other services. And so we did that by providing telehealth services within community organizations, by going into community organizations, and to work with outreach workers, Indigenous navigators, and to welcome them onto our unit and to really work as a team. And that's how we started to work with Mathieu and his team.
Okay, context in Canada. That was the worst slide that I had to prepare because I know that everybody here don't know really not everybody here know the context of like Indigenous people in Canada. And for me to condense that, to do that in a little presentation, it's pretty hard for me. So I could talk about land depossession. I could talk about a residential school that took our kids from their community and was like a horror school that my mom went. I could talk about the 60s school that they took the kids in the 60s and took thousands of kids to make them be non-Indigenous. I could talk about the Indian Act that the government created to decide what is the identity that we still have. My number is 076670676301. I could talk about the 24% of the federal prisoners that are Indigenous, while we represent 5% of the population. I could talk that 50% of the women in prison are Indigenous, while they represent 5% of the population. I could talk about the 54% of the kids in foster family that are Indigenous. Could talk about a lot of things, but I don't have the time to talk about it. And for me, those statistics are always pretty bad because I'm not good at this statistic. According to this statistic, I'm not supposed to be here so much here today. I could talk also about the insecurity of the people when they go to the hospital. In 2020, a woman called Joyce Chakwan, 37-year-old woman with 7 kids, went to the hospital to have health care, and she get killed while doing a online Facebook thing. She was killed not because she was sick, she was killed because she had because of the systemic racism. And while she was getting killed, she was getting insulted, and we all see that through Facebook Live. That's what happened in Canada right now, and that's how we enter in those systems that were created to assimilate us and are still like that today. So that's the context. Sorry for that. Different approach. When I did this presentation, I was also, how can I switch from approach to what I just said? But navigator, if you have to explain to somebody at a Christmas dinner and like a weird uncle that you don't want to talk, you can say, navigator is somebody that support people accessing care. But for Doctor of the World, what we did was a bit different than that. Like you can see right now the team that we had. Some people left, some people stay, but that was a team for a moment. And what I'm gonna tell you today, I'm just a speaker, a teller, because what we create was more than just like a statistic and stuff and way to do. It was more like alive and a way to do that's difficult to put in a little box. And I don't really believe in the one size fit all. So that's the team. They are really awesome. Our approach was a really, really strong community-based approach. Sorry for my English again. The reality of our community was we really believe that the strength of the community, the resilience of a community was one of the main strengths we had in the way we were working. And that's why all member of the Indigenous navigation team was peer and like with deep experimental knowledge. And we were really believing that the first step to be effective was to be involved in community. That means if we want to talk about healthcare or health, we had to be part of this community, help, and create a big link, a link of trust in between worker and the people. So at the end, people that we hire and was part of the team was a part of the community, and that was one of the main points of our team. It's just gonna take 1 second to breathe. Support as a form of care. I remember when I was younger, the first time I heard about medicine, I was like a little bum a little bit in my community. We were doing like a lot of like trouble, and I got the chance to be involved in a project that we were working with medicinal plant. At the beginning, for me, it was more like to get a job and to find a way to live. But at the end, this project brought me in the land with the elder, and they teach me about the plant and they teach me about medicine. And the first thing I learned with the elder was that when we were going to the land, I was asking them always, okay, this plant is for what? They were like, this one is for everything. I hate that because I was like, everything, that don't make sense. And slowly they start to teach me that the medicine was not in the plant, it was to go in the land. And the medicine was not like to drink a tea, it was to say thank you before collecting the plant. And slowly I started to learn that medicine and like healing was not about like a wound, that was about a process. And coming from a really traumatized community, that was a bit of a revelation, because for me, like, using drug or using alcohol was a bit like a way to survive. But I learned that I had like a different way to heal. And I also remember when I was young, there were like this like youth community center that was an approach of like abstinence, and they had activity of drumming. And for us, the traditional drum is a really strong medicine. It's a really strong way to heal. And we didn't have access to the drum because we had to be sober to touch the drum. And for me, I was like, I didn't know I was so full of trauma at this time. I was young and funny. But that was like a little bit of misunderstanding. And when I moved to Montreal, to a big city, I learned about the harm reduction approach. And for me, it was a bit of a revelation, because it was giving me access to something that was called hope and a path that I was able to follow. And it's transformed a lot my way to work and my way to see how I work with people, because I feel that harm reduction approach helped the community to reach some stuff, but helped me also to handle what I see every day on the street. Because for me, the goal is not to go to the hospital and see the wound and like heal the person. The healing is the process. The healing is when you walk through an hospital and you feel the trauma, you feel the insecurity of the person, but you still walk with the person and you touch this thing that nobody want to touch, and you come back. That's the healing. That's the medicine. And that's what we start to work at Montreal, at Médecins Doctors of the World, with people. We start to work to the process to go. And we, by time the project at 5 years old, at the beginning, we were saying that Navigator was not like professional, we're like different. But at the end, we start to realize that we were the professional, and the support that we were giving was health maneuver. I don't know anyways. But the support we were giving, that was our medicine. So that's transformed completely the way we're working inside the Doctor of the World, because Doctor of the World back in the days was an organization with health professional, but we end up being like half and half professional and people with living experience. So we start to give our advice or idea and to be part also of like the medical plan. and we start to add like real benefit and real destruction of the barrier that was blocking the access to people that we work with. Am I still in time? Oh, I'm pretty. Huh? So we transformed that like that, and thank you very much. And also we work to promote care and break the barrier. And how we managed to do that was to, when we get inside the hospital, when we get inside the hostile place, because that's the reality. When we go to the hospital or the system, we feel like we are in a war zone. But when we start to get in, we start to create link with also the professional inside the hospital and try to create a little corridor to have a path that we were feeling trust. And when, as a worker, you trust the people where you go, you can give that to the person that you accompany. You can share trust. And that was a big part of our role also, to be able to create a real path that success to treat our people. I'm gonna stop with that.
So it's tough to follow Mathieu after this, but I'll try. So being in a hospital-based service, we really used a more Western biomedical approach to harm reduction, which focused on reducing health risks related to substance use. So we provided and promoted preventive measures, provided health monitoring, medical treatments, and really tried to integrate more and more healthcare into our services. And that was great for most people, but we were really missing the mark by providing just this for Indigenous community members. They would come to see us once, maybe twice, but wouldn't come back. And the whole our view of harm reduction wasn't really resonating with them either. And it's only once we started to work with Mathieu and his team that things started to change. We started to really connect, to better communicate, to engage in conversations, and to have that trusting relationship. The clicker. And so while the biomedical approach focuses more on clinical interventions and disease prevention, Indigenous harm reduction centers on a more on healing from colonial trauma, honoring traditional knowledge, and restoring balance. And it's really by putting the two together that we were really able to support community members. And so there's a concept that was coined by Mi'kmaq elders, Bartlett, Marshall, and Marshall, called Etuaptmunk. Sorry if I'm not pronouncing it properly. And it basically means a two-eyed seeing approach, where you're learning to see with one eye what is best in Indigenous knowledge systems, and with the other eye what is best in Western knowledge systems, and learning to use both eyes together to provide a more holistic and for the benefit of all.
This quote was made by an elder from Innu Nation. No, I'm kidding, that was me a couple of days ago. Diverse forms of collaboration have the potential to fundamentally transform healthcare practices, fostering approaches that are more human, culturally responsive, and equitable. They also pave the way to a collective healing, not a physical, but also social, historical, and I will add spiritual too. It was a really interesting way to for me, because when I end up at Doctor of the World, I didn't knew like so much healthcare. Like I was coming from a little community. I work in a lot of things. I've been an activist. I did a lot of stuff, but I never went so much to hospital. I was trying to don't go actually. And it's while going to hospital and living super intense situation, then I met with some really interesting people that really believe in our way to work. they really believe in our way to see health and medicine. And that was for me, like a really helpful and a really meaning way to create link inside of the system. We could we actually do that also, like create like a beautiful paper with like, we're gonna have special access for indigenous people and the health system. But the reality that it's the real way to create a real link, it's to be one-on-one, and it's have to be community-based and like community-based and like really strong bound. Like the trust is not, for me, the trust is not coming from a paper that you sign. The trust is coming by going into Colombia with somebody and to experiment stuff. And like also for us, that was a big point that we had, is that the professional see in us a way that they were able to improve their services. Because when the navigator was present, the service was able to occur. Sorry, my English is bad for those kind of things, but they see in us also a way to collaborate and succeed to give services to people that they were usually really hostile to each other. So I think the collaboration have to come from the field. The collaboration have to come from people that we work together, because we had like some patient that we had together and that we trust, beloved, and pass away in the time we were working together. And that creates so strong link, because right now when I'm here today, I'm talking for them, I'm talking about them. So I really believe that if we want to change the society, if we want to change the system, we talk about decolonizing a system. But my approach, the approach of navigation, it's not an approach that's only effective on indigenous people. It's an approach that could be effective on everybody. That's what is decolonizing stuff. Our approach is not an approach that is just an approach that we're gonna give to people. It's an approach that works and that's respectful for human being, and that we should all inspire ourselves. I think that's all I got.
Matthew, you said you were more comfortable on the street, and I could see it with that OG stance. It was great. I was like, yes, he is. You have the long hair? I was like, okay. That was amazing. Thank you all so much. And I'm really excited. We have 18 minutes left for question or discussion. Like I said earlier, we also would invite folks to comment on some of the things that we've been talking about as well. So questions, comments, and then...
Yeah, oh, sorry, I'm too loud. I don't even need this sometimes. But yeah, my name is Ahmed Said. I work with the African Network of People Who Use Drugs as a person who use drugs. And I'm really, sometimes it's very good to listen to professionals who have concluded good job on our behalf. It shows care, and I really was touched because most of the health system we have is about take your cup of methadone and go. They really don't care other avenue of life. And I like you are introducing something very difficult, particularly in a state where we are about numbers, about data, the healing part of touching me as a person who accessing services. I don't know really, maybe if you could expound the impact of it of what you practice. Secondly, I think to Gaia, you've presented a very brilliant and I'll say diplomatic findings. But again, I would still go back to you, like, how can I interpret it as a layman person? If I read this, I know what is NPS, and I interpret it to a local, I know it was specific for that country, but for the sake of us learning at the global space, how do I interpret it to an indigenous in Lusaka, Zambia, in the rurals of Lusaka, Zambia, in the rurals of Guinea-Bissau? So I think if also you can share the model, the simple model on how we can interpret this, I think that will be very. Otherwise, I'm not saying your presentations were brilliant and at the par and very, very timely. Over to you.
Hello. Okay. For the expand question, I'm pretty sure everybody in their country have like everything to build their own medicine, if I can say it like that. We just need to trust that our medicine work. I do remember when I was at the organization with the medicinal plan, the elder was really scared to share to the scientific our plans because they were scared to. The scientists said that no, they don't work. That was so scary because it was so important for us. So we have to trust what we are, and we have to trust that our way to do is good and it's relevant, and we got to trust each other.
Ahmed, thank you so much for your nice words and and for yeah, about the question, how do we interpret these findings in the more simple terms and less diplomatic? I'm aware that maybe it was a little bit more complicated language, but so the issue with NPS, as I mentioned in the beginning of my presentation, is not only something that happens only in our region or only in Kyrgyzstan. It's actually indeed happening across the world. And I think what Atika and my colleague Sergei Bisanov is here representing the organization is doing is really amazing work. And it's really tailored to NPS users. It's really something that I think is grounded in empathy and understanding people and meeting people where they are. So really the importance of realizing that NPS is unpredictable because of how how quickly the formula changes and how quickly the drug market changes. It's really hard to immediately adapt all the services. And I know that the harm reduction providers really struggle with that a lot. But I'm going to pass the floor to Sergei to say a few words, and I'm going to translate then.
Всех приветствую. Я, к сожалению, не говорю по-английски, поэтому да, Гая переведет. Ну, если я правильно понял вопрос, то, наверное, сейчас рано транслировать это на регион, потому что это пилот у нас в Кыргызстане. И смысл, наверное, всего этого очень, чтобы его точно отразить, это то, что некая система, которая происходит сейчас, бюрократия, да, мы сообщества видим, что наркосцена давно изменилась. И вот о чем говорит Гая, НПС, да, там идут споры, трудно. То есть Кыргызстан всегда был опиоиды и каннабиоиды. 7 лет, как появилась куча новых наркотиков, страна как будто не видит этого, да, все работают дальше, но у нас сейчас стоят проблемы, это мифедрон, это альфа-ПВП, 2 основных наркотика, которые используются. Это кокаин, да, который я сейчас смотрю здесь, допустим, в Кыргызстане 0,15 это уже уголовная ответственность, а 1,5 грамма кокаина это особо крупный размер.
Okay, I'm going to translate. But I'm going to translate for everyone else. Yes, there was a small translation couple there. So what Sergey is saying, at this point, it's a little bit early to translate this on a regional scale and what is more on the global scale, because this is still a pilot project. However, the objective of this study is to inform the policymakers on the national level to start finally changing, because it's highly bureaucratic. Of course, Kyrgyzstan is not as special compared to other countries, but the emergence of NPS has been happening for more than 7 years already, and the system has not adjusted, nothing has been adapted, so the country stakeholders still keep shutting their eyes on the situation in the country. So, you know, Sergey has mentioned again, there is a high use of methadone, alpha, PVP, and also cocaine is present. And if you take even less than 0.15 grams, it's already an offense. And if you take more than a gram, it's you end up being in prison.
Ну, то есть идея в том, что мы как сообщество видим, что все программы должны измениться, все работают, как будто есть героин, а уже 7 лет героина нету в Кыргызстане. И очень трудно, почему-то очень трудно людям показать, что ситуация изменилась и надо работать так. Все просят и заявки глобального фонда, все просят исследования, докажите, докажите. И мы пытаемся это сейчас сделать. То есть есть много разных факторов, там, где задержание, где, как Гая сказала, судебные акты, экспертизы. Они все говорят о том, что в принципе героина практически нету, но есть параллельно уже давно проблема с новыми психоактивными веществами. Еще мы их называем там стимуляторами, да? Ни врачи, никто не знает, как можно помочь. Ну и вот попытка этого проекта всем показать и доказать, что ситуация изменилась, что надо меняться тоже вместе.
So,
Если получится, мы обязательно поделимся своими результатами.
So, in a nutshell, basically what Sergey is saying is that the programs have not been adapted. There was no heroin in the country for the past 7 years. As you saw in the study that I presented, there was a very brief period that, you know, it appeared and disappeared immediately. However, the system has not adapted. Doctors are not aware of how to work with the situation and how to help the NPS users, how to adjust what they do to the current situation. So that is the whole point of this, is to provide and to collect evidence to bring it to the table, because right now everybody is asking for this. However, it has not yet been performed. So now this pilot project has been carried out in Kyrgyzstan. It's planning to be done in Kazakhstan. And Sergey is happy to also share it with a wider group of countries and regions once this is finalized.
Thank you so much. All right, we have time. We have time for 1 to 2 more quick questions.
Kia ora. Thank you so much for your presentation today. I have a question for Mathieu and Dr. Stephanie. This two-eyed approach is something that I promote, this relationship, this safe relationship between Indigenous communities and medical space. And I would just like to ask how you came to work together. I think sometimes there's Indigenous communities here and there's medical space over here, and there's this gap, this transition zone. And I know that there are a lot of communities that want to be working in this two-eyed approach because there are definitely benefits that we can safely bring together from both communities to create culturally appropriate healthcare. Could you please just briefly give a timeline on how you came to work together so some of us can have a bit of visibility on how we can create these authentic relationships? Thank you.
I remember one time we worked with somebody with a syphilis together, but not sure if this thing. We work together because it works. That's the first point. I think it's even with like other organization that's more like street harm reduction approach. I realized in Montreal that we were, as you said, there were like a little gap between even like ONG, like little organization, and Indigenous people living homelessness in the street in Montreal. We didn't have the link because I think it's a bit of like the shy racism, if I can say it like that. It's sometimes because you're scared to do something wrong, you don't do anything. But I think Dr. Massa, maybe you have more big remember than me. I think the main idea is we start to work together because it was working. We're able to help people to do some stuff. Dr. Massa for me is like such a incredible access to health because I can call her on our phone. So it's not something you have so much in like big cities and big hospitals, but it's the person by person. I really believe it's the person by person relationship that creates something bigger after that. So when I met with somebody at the front office of the hospital example, I always try to give my card and like push something to create a little link, a little moment that we're gonna start to build the trust. I really believe that for giving access to my people to health, I need to build trust also with people that I don't trust at the beginning.
And I think one thing also that we did on our end was to really do a lot of outreach, to go into the community organizations and to say, hey, we're here, how can we work together? And a lot of the time at the beginning, nobody wanted to work with us because we were seen as a very hostile environment. But slowly, as we started to make those connections and those relationships, we started to get known as people who were willing to work with others and to change the way we work. And so slowly things evolved and changed, but it wasn't an overnight thing. And it's been really something that's taken quite a few years to develop and is just getting better and improving. Yeah.
There is a real problem with, not a problem, but it's complicated with credibility also because a lot of navigators that come from like organization that's really close from the people we go to hospital with. Sometimes is our cousin, like our brother, or like people from our family. So when something wrong happen at the hospital, when we see racism, it's easy also for the worker to just get mad and get kicked out of the hospital. So it's a real thin line to walk to be able to have access, but for me, I use the street work like a strategy. I have like a pack of like card and contact, and everywhere I go, I always call my contact and try to create like a little like a spider web around the people that gonna be able to change stuff that one day I'm not gonna be needed there anymore. Yeah.
And maybe just one thing I can add is that, you know, at first, no Indigenous community member wanted to come and see us. And it's because of the work we've done with Mathieu and his team that slowly people have started accessing our services. And it is such a beautiful feeling when, you know, a person at first that wouldn't even talk to us on the phone is now coming to see us on their own without the navigator, where we've really built that relationship. I mean, that's the best feeling.
Amazing, thank you, everyone. We only have 1 minute left y acabo de aprender algo. Hoy es el cumpleaños de Ángel. Feliz de cumpleaños, Ángel. Happy birthday, Ángel. Yeah. Thank you all so much for coming to this session. I hope to see some of you who are interested at the Healing Centered Harm Reduction workshop that's in 3M at 4:30. And I forgot to mention that I also made little cards for body autonomy. If folks don't want to buy the book today, you just have to buy it in 3 months before my free QR code runs out. Awesome. Thank you all so much for coming. I hope you can come ask your questions to the panelists if you didn't get a chance. Buen día.